Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro, and I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. We are back on home turf for another little solo episode, Brett. So today we're going to talk about a topic that I've been hearing you speak for pretty consistently, 7 years now, but it's been a recurring theme in your lectures, in your seminars and things like that. And that's this idea of a conceptual, almost like a philosophical question of when are your patients done? Like, when are they actually done with treatment? But before we get into that, I just want to make a little plug here for the first annual Neurodynamics World Congress. I know we've been plugging it for a while. Don't forget to sign up, please. If you go to Gestalt Education or gestaltedu.com/courses, there's a banner for it, and it's got all the information. It's November 3rd through the 5th. This includes everyone from Michael Shacklock to Dr. Leahy, Mike Leahy, Antonio Stecco, Brett Winchester, Annie O'Connor, Jeff Bove, David Seaman, and of course, Michael Shacklock. But this is a weekend that it's going to include hands-on. It's going to include lectures. It's going to include like your
and Bill Morgan.
And Bill Morgan. Yeah, that's right. Your first kind of, our first dive into real integration, Brett, and it's going to include manipulation as well. Mm-hmm. And it's going to be us talking about how we actually mix and match these together, with the theme being neurodynamics as kind of like the center core.
I think, just to hear, there's just never, Antonio Stecco hasn't been with Michael Leahy. I'm excited for those two to, be together. And then also Michael Shacklock and Michael Leahy have never been together. So I think it's kind of, they're looking at nerve entrapment from two different ends of the spectrum. I think like having that, it's going to be insane.
It's going to be really awesome. So make sure you check that out. We'd love to see you the first weekend in November at Parker University. And then we have just updated our courses for next year. We pretty much have our 2024 scheduled together, which is pretty early for us, Brett. Mm-hmm. Pretty, patting your own back there.
Two.
Every year we bring A, B, and C, DNS A, B, and C through Troy with you, Brett, and then Rich usually helps us out at the end with the C course. And then this year, we're super excited to have the DNS Peds route. So DNS Pediatrics 1 with Marcela, and then DNS Pediatrics 2 with Martina. The first one in February, and then the second one in October. And so these are probably the two best practitioners when it comes to not only understanding pediatric conditions, but the treatment of those and how to apply DNS to the pediatric population.
Yeah, no, that's for sure.
The cool thing too, we always talk about with Marcela, nobody probably understands scoliosis better in the world than Marcela, especially when it comes to conservative care of scoliosis. And so that's going to be a deep dive that weekend, and it'll be super awesome. So anyway, that's our plug. We're bringing out taping. So my big mentor, Greg Dorr, if you're listening to this podcast, you probably listened to our episode with Dr. Greg Dorr. So that's going to be functional taping for musculoskeletal injuries. This is a course I'm super excited for, one of my top fives. And it's going to be basically all encompassing. You're going to learn how to use kinesiology tape. You're going to learn how to use strapping tape, understand sideline care when it comes to kinesiology taping, but also just wide athletic tape or athletic taping. And so it's going to be really, really awesome. And then that gets combined in with some awesome rehab and some other things like that. So we're super excited for those courses. We'd love for you to come check out Troy and Winchester Spine and Sport. And we'd love to have you there. So anyway, let's go back to our topic, Brett. So this philosophical question that I've heard you bring bring up quite a bit. And usually you kind of leave it open-ended and then we kind of dive into it throughout the weekend, whether that's an MPI seminar or a DNS seminar, or, it's a lecture on low back pain. But can you mainly just, I don't know, give us some inspiration on where you're at with this? What's your answer to this philosophical question of when is your patient actually done with care?
Well, I think, this is something that, whether people want to admit it or not, and whether you're young or old, this is a struggle that everybody has of knowing, when you actually release a patient. And I think most people who are listening to this, they're definitely on the functionalist camp. They're not usually pain chasers and things like that. But in saying that, chiropractic is very, very good at changing pain also. For the chiropractors out there that are, we kind of call them one and done, where you're more like the aspirin, but you're a huge gift to humanity because you're able to help people without, drugs and surgery, things like that. So, it's definitely not a knock on that. I just think that, the important question to ask yourself is, what are you dealing with today? Are we dealing with a Ferrari or are we dealing with a Ford Escort? And I think, you can't treat 35 patients in your day like a Ferrari. You just don't have the bandwidth to be able to do that, nor do you need to do that. Mm-hmm. So I think having enough tact to walk in the treatment room and understand what that patient needs from you today, and really kind of almost have a minimalist dosage approach, which is what's the minimal amount that you can do to have the greatest effect throughout their kinetic chain or their closed kinematic system. And in saying all that, if we, in DNS, or if we're talking about soft tissues, if we're talking about manipulation, I really use the analogy of the normal developing child, which was originally definitely a DNS thought. So, if we're comparing our patient that we're seeing today to the normal developing baby, how do the joints spring or play? How are the soft tissues? Is there tension tone in the soft tissues? How's the muscle length? So you always have something that you can compare it to. So in that first year of life, everything, if physiologically developing in the way that we want, the muscles are all being picked in the most perfect synergistic way. So we don't have any of those entities that we're so used to seeing to our earth dwellers as they move along in their life. So we don't have trigger points in muscles. We don't have tension tone. We don't have joint blockage. So then that in itself gives you a beautiful audit to come back to see, even after a visit or two, we're not expecting them to be perfect, but what we're expecting is to be trending in the right direction, right? So what that means is, if you're cutting a patient loose today that, let's just say, they're 100% out of pain, are we saying that there's no trigger points, there's no tension, there's no tone, there's no joint blockage? Of course not. And of course, this is all on a continuum. And this is about what do we need to do? If you're working with, for example, a professional team or a professional athlete or a collegiate athlete, or you're just working with somebody who wants to be a Ferrari, you have the chance or the ability, or you're lucky enough to literally give them Ferrari-like care, where you are paying attention to all of these things. And you have tools to be able to literally help them with all of these things. And, your post-treatment audit will show this. And then also the next time that we see them will also expose how well you've done the previous time, or maybe how well they've done on some of the things that we're doing through home exercise. But I think this is probably the patient that we all went to school for, the one that you are able to just absolutely take their care to a level that is so high. And then we're basically, our goal is returning them back to the state of the body in that first year of life. And that's a really exciting feeling, I think, especially for a young clinician, to see that you and I can make an intervention, or we can make a change to where you are changing all these things. Because once a joint is not being stabilized in the most ideal way, then what ends up manifesting is tension, tone, trigger points, and eventually joint blockage. So what we're seeing all day long is basically the central nervous system way of creating protective patterns. So the downside of that, though, especially if we're dealing with our athletes, is a decrease in range of motion. So if we're talking about a hip joint, for example, that's not being stabilized the way that we want, so we're going to find trigger points, adductors, hip flexors, external rotators, internal rotators, adductors, the whole bit. So that is going to allow you to still get from point A to point B. But the central nervous system is so amazing through adaptation and compensation that we are now limiting range of motion, which is what you'd actually want to have happen if we're not stabilizing a joint in the right way, but all at a consequence of joint range of motion. So the hallmark of good athleticism is, of course, full range of motion. So if all the muscles around a particular joint have trigger points, tension, and tone, then we're limiting the range of motion, although we're giving the body a chance to still be able to survive. It's very like a primal thought. Like it's very adaptive, very amazing that the human body is able to do that.
Yeah, that's right. Well, and you bring up a good point of adaptation. This is another kind of hallmark of what we've talked about a ton on this podcast and over. Just because you can adapt doesn't mean you should.
Right.
And that's no different than with our athletes. I mean, you could let an athlete, we're watching hockey today, with big old trigger points that are adductors because that's what they use all day long. But like nobody would say that they're better off for having those.
No, I agree 100%. So, and again, so I think it's really important that we expose like what this actually means. So somebody could come in and they have a pain syndrome. Well, I could give you 40 jumping jacks and you could come back tomorrow and say, well, I feel better. And so, there's, and I get that. I mean, that there is certain patients where that is a good approach, especially like in a chronic pain camp and things like that, which, we all know that.
Another discussion. Yeah.
We got to be careful though, that we don't treat the 5%. We don't treat the 95% like the 5%. So, and I think that the one thing that I'm always amazed at every day in my life is the ability of the human body to adapt and compensate for things that aren't well, not just in the musculoskeletal system, but also like in the functional medicine world. So like the body, it's a testament to the human body to be able to do that. But that doesn't mean that we are necessarily wanting it to do that. I mean, the analogy that, I always give is, if you've ever been undergrad and you've gotten used to on a football Saturday of having 12 beers or 15 beers. Most people, as they move along in their life, they couldn't continue to do that continue to do that. So just because you can do that doesn't mean that's what we're wanting the body to do. Sometimes usually it is that chronic pain patient where we just need them to move their body. We're going to give them a general movement strategy. They're going to do great. So just because you're in that camp doesn't mean that we're not telling them not to exercise and do things. So of course we are. So we want everybody moving their body. But I just think for the people that are out there working with people, and I mean, a lot of people are in this group, you have the tools to create absolute, Ferraris out there with the tools that are out there. And you shouldn't be ashamed of that.
So that you brought up a point on dosage too, Brett. What does dosage look like for those two different camps? Like when you have a Ferrari in front of you, like what is a realistic expectation for making a change and for those body to be a Ferrari versus someone that's a Ford Escort, you're a 50-year-old middle-aged man that is just laying bricks all day. Like, what do those two dosages look like when it comes to treatment for you?
Well, I mean, let's just take the 50-year-old guy who's, he's out working, he's, hurt his back, blah, blah, blah. And, we all have that case where we give them, 10 press ups and, they're miraculously better. So that is in its own camp. And let's just say that same patient is, they go home at night, they smoke 2 packs of cigarettes a day, they're drinking a 12-pack of beer.
Sounds nice.
So that case, they don't necessarily need to be a Ferrari. They just need the right thing at the right time. And I mean, the one thing Mark King always taught us was that, make it easy for them to come, make it easier for them to go, so like that's a different patient profile than, if you're working with a college or a team or an athlete where we are basically wanting to change function of their body. So to me, I mean, you're going to need twice a week for 3 weeks minimally to really start to change some of those audits that we're talking about, which is, it could be joint range of motion. It could be a functional test. It could be tone and tension and trigger points, blah, blah, blah. And so that is going to take you a little bit longer to be able to do that. And, but I mean, so it's about knowing what that patient wants from you. And the fascinating thing for me is it's amazing. Like, as I move along in my career, like if you say the right things, how many of your patients actually are wanting what we're talking about without even realizing it. And that all gets done in a really good trial of care. So that's usually for us here at our office, that's 3 weeks of a couple times a week for 3 weeks. And then we say, we'll reevaluate you. Mm-hmm. And then we decide what the next steps are going to be. And at that 3-week mark is a really nice time to start really kind of coming back, letting the patient know. So there's two sides of this. There's the subjective pain experience, and then there's the functional piece of this. We're really concerned with the functional piece. And when the patients understand this functional piece, I'm telling you, it's like an epiphany moment in your career, because really then they're not running you around. Really, I mean, if your patient didn't have a mouth, that's okay. Like, we can still work with them, and we can just start working with their body and changing these things. And that is one of the miracles of what we do, and one of the gifts. And I think if the patients understand that, it is such a liberating feeling for you, because it really doesn't matter. It really takes a lot of the pressure off, because all you really at the end of the day can do, if we're just talking about the musculoskeletal piece, we get joints moving that are stiff and the plane of motion that they're stiff in. If the joints are hypermobile, obviously we're going to stabilize them. We have tools to work on tension, tone, and trigger points. We also have tools to work on how the central nervous system is able to utilize the muscles correctly around these different joints. And that sums it up right there. Like, if you don't know where to start with your patient tomorrow, start there. And then you have, like, what we call in the continuum of these patients, you have on one side, which we've talked about this before in a podcast, where you have a chiropractic or a physical therapy miracle, where you do 10 press ups, you do something, and you literally create a miracle. And then you have on the other end of the continuum, you have an orthopedic intervention like surgery or something like that. And then in between, you have a black hole. Chiropractors and physical therapists do a horrible job of managing people in this black hole, because really what we need to be doing is we need to be educating them on changing function. And like I said, this unfortunately takes a little bit of time to do this well. And patients are actually really kind of used to this. You don't walk into the orthodontist today, get braces on your teeth, and then show up tomorrow and be like, you know what, like, get the braces off. I think my teeth are straight. Right. No, it's like it's a 2-year process of a lot of pain, anguish, rubber bands, headgears, to get things functioning the way that we want. And, sometimes I'll use working out as an example. You don't go to the gym one time and, so anyways, those people are not being managed well. And then, like, let's just say you do the one and done and they relapse. So, and I mean, this will happen to the one and doners. I know, because I started my career one and doner. Like, I spent a couple of years definitely thinking that I was going to fix everyone in one visit. And then I finally wisened up. But you have to have the skill, Taylor, to be able to confront people on function, which means you have to be bought into it. If you're not bought into it, there's no way you're going to be able to sell it. And if you do it well, you're never selling anything. In fact, it's the most natural, organic thing. You don't have to sell it. Like, they want it because you've been given one body. Like, to me, it's like, I mean, are you kidding me? Like, what's more important than having your body function in a good way? Right. A majority of modern Americans, they actually will treat their car better than they'll treat their body. So, which is okay, but we're there to kind of just point out the obvious to them or confront them on this topic. And then if you put it the right way, it's like, yeah, there's a benefit to seeing you, I don't know, once a month, once a quarter, whatever it might be. You should not be ashamed of that. I'm telling you, if you listen to Andreas Eklund's research on maintenance care, or in others actually now, like, you will clearly see we're costing the healthcare system less money on a maintenance program, and the patients are very satisfied with that care. Yeah. Are you going to have that, that less than 1% that's not going to buy it? Yeah, you are. But I would argue that they're not great patients for us anyways, right. And anyways, even like challenge yourself, like get that 1% turned into the other camp. And, or like, if you've done a good job at changing pain and function, then we can let them go. Like, I mean, right. They don't have to be like getting their mail at your office by any means. Right. But I think that, like, people act like they're going to get addicted to your care or your hands. And I would just like kind of politely point out that if, it's not like people here are like, oh my God, Taylor, like, I'm just addicted to your hands. Right. It's like, no, you're like helping them. Just like you go to the barber to get a haircut. Could I cut my own hair? Yeah, I could cut my own hair, but I mean, you have these people that you're getting advice from in your life, so they're basically helping you, and you should not be ashamed of that, in my opinion. Sure. And I think even like you'll hear the evidence-based group people, one being a Shirley Sarman, another being a Gray Cook, saying things like, you should have a checkup, just like you do, like with your cardiologist or whoever it might be. Yeah, exactly.
Yeah, and I think it's a good point too of like. Having that conversation, I guess, because if they are a Ford Escort and they just want to be out of pain after you've changed those functions, maybe how do you approach that patient of the next thing? We kind of talk about it. Usually it's organic, like,
right.
Hey, you know what? Like you do a physical labor job, it'd be worthwhile for you to see me once a month. But then maybe can you talk about that first? And then what about on the athlete? Like let's say we have an athlete in season, post ankle sprain, function is restored, their balance, their return to sport is perfect. What do you say to the parent in that situation of like, hey, this is kind of how often I should see them in season and things like that?
I'm a really big fan of being a chameleon and trying to meet people where they are. I mean, you can take like a harder stance and you can be like, when you're ready to do exactly what I want you to do, then you come back and see me but I feel like I'm better off just meeting them where they are, kind of giving them a little bit what they want in the front end. And then I always have a hidden agenda. Like I'm always like in the back of my mind thinking, well, today's not the right day, but like I am going to convert this patient. I'm going to make them lose 100 pounds at some point. And that doesn't always happen, but that's kind of my mindset. And one thing, once I started believing in that, people will do what you tell them. I mean, I'd say that like they'll listen to you, especially when you've been at it long enough and they actually respect what you're saying. So
I think it comes down to confrontation. You kind of talked about it a little bit ago, just confronting it. Like, hey, like, this is what you do. You've had these flare-ups in the past. Like this is a great option for you to hopefully as like an insurance policy almost you don't want to use it, but you're not better off for not coming to see me basically.
Because if you undertreat, they're going to hurt your batting average, which means like if you don't manage the case well and then they go off and then they'll tell everyone, well, Taylor wasn't able to help me, when actually you could have helped them. You just needed more treatment. I mean, that's my legendary story of being in Troy, Missouri. And you now feel it too, where we see all our patients everywhere. So like, if somebody's doing something outside of what you've told them to do, you're going to hear about it. Like, and so, I mean, and that's how I got on a functional path. I had a couple horrible moments where I saw my patients in Walmart or Walgreens and went up to, receive the compliment. And instead of them giving me a compliment, they're like, yeah, I ended up doing something else. And that happens a couple times and that will shake you. But like, if you're in downtown Manhattan, you don't see your patients, so. Or like the orthopedists, a lot of times they don't see their failures because the patients don't come back to them, So to answer your question though, like the athlete, like let's just say that you came to us with a shoulder problem and we recommend all our throwing athletes see us once a month in season. And that's when they're 100% pain free because there's so much that we can be doing. We're like the ultimate insurance policy for them. So, or like if you're a marathon runner, well, of course, if you're, we had a bunch of people that were training for the last Ironman. Well, yeah, you're here every 2 weeks, just, and I don't love the term maintenance for what it's worth. Like I feel like, but that is a term that resonates with the profession and people kind of know what we mean by that. But,
I don't know if I've ever heard you say maintenance to a patient now that I'm thinking of it. I don't think I have either. It's just kind of like, I don't know, like a checkup, I guess, or I don't know. Like, I don't know what I say. Yeah.
You know what Kevin Christie uses is performance care, which I like that. I like that better than maintenance care, but I don't even like, I just, at the end of the day, I believe people should be seeing us. So like, that's just what I believe. And I almost get offended when people don't want to do it. I mean, as weird as that sounds, because I just feel like we're such a bargain for what we're doing that like, why would you not? So, and again, I just want to reiterate though, like in the end, even if you're like on a mate, you're still costing the healthcare system less. I want to make that point because people think, well, that's a bleed on healthcare. No, it's not. No. It's showing that it's actually saving healthcare cost. And then also because we're such good gatekeepers, I think it was 2013. I'm pretty sure the author is Webster, where they basically found that, depending on who you saw initially, it was basically like a $13,000 difference in, because like if the patient shows up at their primary care, then you have all these down the road costs, epidurals,
X-rays, MRIs,
PT imaging, the whole deal. So like we're actually a huge bargain. The other thing, we are actually there to be working on other things that are potentially popping up in their health.
That's right.
You know, like a lot of us, I mean, I'm a huge functional medicine provider. So like I'm listening to other side of their case also, like, so I don't know, maybe I'm a homer for the profession, but I just feel like we have a skill, and we are, especially the evidence-based group, which we all are, we think we're just aspirin. We're only working until they're out of pain, where, I mean, we have so much. If the patient comes to you, even if you're a 100% McKenzoid, like even if the patient did not have a complaint, even in the MDT model, through range of motion assessment, you still have a million things you could do with that patient today.
Absolutely.
Yeah.
We had an episode early on called Silent Derangement. And that's the same thing. Like if you're just like, but also that requires you to pay attention. What I think is another big theme of this podcast is paying attention to the things in your patients. If you're not paying attention to their left foot dorsiflexion when they have a low back complaint, how would you ever know that that is restricted, or how would you ever know that that's not a concern for them going forward?
No, that's
and I can't. And like, how many times do you start working on something like their left ankle or something like that? Like, oh, I kind of forgot to tell you, I hurt my ankle 5 years ago or something like that. Like, how did you know that? You're almost like a whisper, and it's not that you're doing anything crazy. You're just like paying attention to things throughout the body that could become problems.
Yeah. Or like you see a 75-year-old patient today that's never been to a chiropractor or physical therapist. They have spinal stenosis. They have the stiffest thoracic spine you've ever felt. Do you think, one, if you go for broke today on them, you're going to break their rib? I mean, like if you go for manipulation in that really stiff area. So instead, what do? We slowly but surely through home exercise and good treatment, we start mobilizing that area. Okay, now 3 weeks later, now we're actually starting to release those joints in that area. Mm-hmm. Now when we go to joint play it a month later, now we're starting to establish good joint play. Do you think that patient's doing better in a month? Hell yeah, they are. Yeah. Right. So that's what we're saying. Like, and again, just compare what you're about to see tomorrow to the normal developing baby. And then you know what ideal is, and you know what you're shooting for. Am I going to get that 80-year-old stenotic back to that? No, but that's the mind fuck that I'm actually working in my brain, as I'm actually thinking about actually doing that, So, and when you do that, it kind of gives you a pathway of what you need to be working on if you do get a little bit lost in the case.
Very true. Yeah. Well, I think like the more we talk about this too, and I mean, just getting rid of the bad, I don't know what you want to call it, like stigma.
Yeah. They kept me coming back.
Yeah. Like treatment plans and maintenance care. I mean, like at the end of the day, like treatment plans are what forces you to be there, to be the hero. The story I tell, and I've told on other podcasts, is early on, we shared a wall, and I was not giving myself a chance to be the hero in the case. I was going to imaging rather quickly, wasn't giving myself those, 3 weeks to be the hero, to let the functional changes get around, let the symptoms calm down, let the, be the hero in that case. Because if we just take a regular route of low back pain, if they do nothing, in 6 weeks, the majority of the time, people are going to be fine, right? We want to shortcut that. We want to make functional changes so hopefully it doesn't come back around. But if you're not giving yourself the chance to be there, to be the hero, then you're missing out. Your reputation sucks then. Your chances of referral aren't very good. Like all these things kind of add up to it.
Well, I think too, like there are other reason, like, cause me, I'm a skeptic on everything. Mm-hmm. So like if the research will tell us, like in average, low back pain, if you do nothing, you'll be better in 3 weeks. If you have massage therapy, you'll be better in 3 weeks. If you do MDT, you'll be better in 3 weeks. If you do general movement, you'll be better in 3 weeks. If you do manipulation, my point is this. So what are we doing, right? So instead, that's why I think also you take the pain out of the equation. And what we're doing is, because again, the body will adapt. So like, although you're not in pain in 3 weeks, I would argue that you're not okay a lot of times. Like you're a functional landmine that's about to relapse, So like that is why you need to be bought into this model. Because if you're just playing the pain game, and the story we always tell is Laura Mosley's story about if a shark takes off your leg, then basically you feel no pain for a couple hours. If I paper cut your finger right now, it'll drive you nuts for the next couple hours. So we need to be very, very careful about walking in a treatment room and having our only assessment be, well, how are you feeling today? Because pain is such a unique, subjective experience that is unique to every single person on the earth. So what's going to determine how you answer that question will be, well, did you have an argument with your spouse this morning? Are your kids pissing you off? How far behind are you? Did you sleep last night? Do you have 2 autoimmune diseases? Have you unfortunately been abused previously in your life? All of these things can weigh into how you're going to basically assess how your pain is today. If we start with a really, really open-ended question like, how are you doing today? Right? So what we do, and I really like this for what it's worth for everybody to just to kind of try and see how you like it, which is instead we walk into the treatment room and of course we engage them. Of course, we don't over assess or ask them too much about their pain in that moment, subjective. We go right to the biomechanics. So what was the main finding that you found? Was it a stiff thoracic spine? Was it a trigger point and the infraspinatus? Whatever the major finding was, or a couple findings, we go right to that to assess. The next thing is our next line of questioning would be activity intolerances. Okay, your spinal stenotic, you said the first day that we met that when you get to the mailbox, both your legs are starting to go numb. Okay, so have you been able to walk a little bit further? I wouldn't expect you to be 100% better at that in that difficult stenosis case. The third line of question would be, this is after you've done the other two. Overall, how would you describe the status of your case? This is exactly how I worded it. Do you think you're better, the same, or worse? And what I've done there with the patient, or what we've done, is we've prioritized what we're looking for. And to them, what it tells us, and it's very liberating for you and I, is that he or she is here to change the function of our case. If we do a really good job of changing function and pain will move along in parallel axes like this until they don't. And when they don't, that means that you're dealing with chronic pain or you're dealing with some kind of structural problem. So back to the hip case, you have a big old gaping labral tear. Well, sometimes no matter how good you are in treatment, like you're not going to get around that. So how do we know if they need surgery? Well, we give them a world-class trial of care, hopefully. And then in 4 weeks, if everything's exactly the same, then we know that they might be headed off to surgery. But again, this is why this is so important. We know that the severity of image findings, to say that it doesn't matter, we'd be foolish to say that. It does matter. But really, what really matters is how good is the trial of care to see as we start to, improve the function, do we actually need a surgery? James Andrews, what does he say? He's like, if you want an excuse to operate on a Major League Baseball's throwing shoulder, get an MRI because you're going to find something. So like the image findings are part of the story, but if you're looking at a pie chart, that's 20%. The 80% is how do they respond when we start to normalize the function around that area.
It's true.
Yeah.
And that's across the whole body and all patient types, honestly. I mean, that's the nice thing is if you just stick to that kind of like way of thinking, like it's
actually
never
pretty easy.
It is. Yeah. It's never going to let you down.
No.
Because then it's easy to confront them like, yeah, it's 2.5 weeks. You're the same. Like something is not right here. Either you need to make a different decision or you need imaging, you need labs, you need something along those lines. And frankly, I think one of my big gold medals is just honesty. Like I am just very honest.
Yeah, you are very honest.
Like I'm just like, hey, I'm not helping you right now. Like I don't like something is not going right. And the patient's just like, yeah, I'm a little bit, no. Like you are the same. Like something has to change. Like either I've missed something. And so today I'm going to just go through and reassess everything. At the end, if I still come up with the same conclusions, we're going to do something different. Like that's going to be our way of knowing whether or not we're doing the right thing. And patients love that. They're like, oh shit. Okay. Like he actually is paying attention to these things, but it also distracts from the symptoms. Like I know that your symptoms are the same. Like we always joke. Yeah. I'm going to walk in. Yeah. I'm going to walk in. Yeah.
They're dying to tell you,
Or I walk in and already know, like, oh, let me guess. Yeah, they're the same. But the reason I know that you're the same is because the same things keep coming up the same. So then that takes us down the next path of what the next intervention is.
But also, to that point, like if you can really buy into your auditing system, and everyone's going to have their own audits, but let's just throw out joint play, trigger points. For us, it would be like DNS assessment. tension tone, just joint range of motion, very powerful. Neurologic testing, neurodynamics, deep tendon reflex, the whole deal. So that's your playbook right there. So what we're wanting to see is your intervention changing those things? If you're on the key link, then whatever that key link is, you're having the greatest effect on all the audits through the body, right? And that is the game within the game that that's where but you hear me tell the story. I'll come in here to our doctor's office and I will bitch like everybody else, but I will go right back in that treatment room and I'm wanting to get the patient better, of course, but I'm also almost enamored and just very curious to where if I change something at the key link site, how that affects the whole body. And that is what I think just keeps people going throughout their career, because you have a whole separate game within a game. And I always say you should be exponentially better at the end of the day than when you walked in that same very day. That's how quickly you can be getting better, and I mean, I'll also speak for myself here. I mean, I am so much better than I was 2 years ago. It's insane. I'm so much better than I was 4 years ago, because every day I'm just really kind of paying attention to what my intervention is and how I'm changing the body. And just, it almost allows you to tolerate that schedule full of 3 no betters in a row that is just you're just damn, what am I even doing? Right. But just play the long game. And we always say it's just such an amazing thing about our profession. You'll go to bed some night being I'm done. I freaking hate this. I'm doing something else. And for some reason, you wake up the next day wanting to get your teeth kicked in again. And that's what I love. That's what I love about private practice myself.
Well, and we're coming straight from the trenches. I mean, we literally just got done. Tuesdays, we only treat half a day. And so, we saw 15 people today or something like that. And
we could never do a podcast
after a full Monday or Tuesday. Yeah. But, that's why we continue to see as many patients as we do. We get questions like that all the time. You're at a seminar Brett probably doesn't see that many patients anymore. No, you're grinding through 100 people in a week, no problem. And I think that's why these conversations are truthful. And, we're always going to be honest with you about these situations. And if we're telling you to do something or asking you to think a different way, it's because we're asking each other to do the same thing in this building right here. And
we have 5 interns watching us to that make sure we're towing the line and not but I think too, another important point would be, when we say maintenance care, that doesn't mean we're just walking in a treatment room, doing a bunch of blind adjustments and walking out, which I think that's another problem with that term, is that's what you're kind of thought. No. We're every case we're taking very, very seriously. And I think too, the other thing, with Western medicine wanting to tell their patients no, slamming the door on their face, you being there to do a really good job of explaining and educating them. I think the patients, they are clamoring for what we're doing right now. And we're in a perfect spot moving forward, because people are really wanting high level treatment and care. And my experience is, when you're around somebody who's had a bunch of people work with them, if you're doing a good job, they'll pick up on it in a second that you know what you're doing, just with your handling skills and what you feel and your education.
I think that's important too. You've mentioned something about when they do come back. Let's say you have them bought in on this idea of coming back to see you every month or something like that. That's another opportunity to audit the body. You may catch something that you missed that last time. Shit, I wish I would. How many times I do it to myself, even once or twice a month now. I shouldn't have put them out a month. This is not good. And I have to, you can maybe backtrack a little bit. Hey, this actually needs a little bit more work, or this got a little bit worse than last time. We need to change something up. Maybe that's an at-home exercise, or maybe it's a different range of motion exercise, stuff like that. But it's always another opportunity to audit from what it was even when you saw it a month ago, not just when you saw it twice a week for a week.
For sure.
It just continues to go. And again, that's what gets you excited about being here. So.
Let me ask you a question. And this is a rhetorical, the answer to this, but just make you think this way. You see somebody with low back pain and you see them one time and you get done and you basically are well, just kind of see how you're doing, right? 6 months later, that patient is diagnosed with METs. Mm-hmm. Okay. Who is negligent in that case, do you think?
Yeah.
Right. So that is why these cases need to be managed really, really well, because as you can imagine, 3 weeks later, if the case is not going the way that we want, well, what do we do? Of course, your antenna goes up. We need to get imaging. We need to find out Maybe you are in the chronic pain category, which means you're never going to tell me you're better, but actually you're functionally better. Fine. But like, I at least got to know that you're not dying of cancer, right? And we can't just like go the most aggressive route. We can't just do CT and MRIs on everything like right off the bat. Right. We've learned that with the cost and the education off the imaging, how expensive that is and how dangerous that is to the patient. But so I think that's also where the functional models where it's all at for every single reason. That's right. Really.
Yeah. It's so true. I love it. It's a
now, is it going to be easy? No.
Oh God.
Like, no. Because like, again, what's hard for a young clinician? One, you don't believe in your own audits, which is hard. And then the ability to confront somebody and look them in the eye and say, the reason you're giving me your hard-earned money is because as it turns out, we're pretty good at changing function on this, and what you can also think of yourself is you are basically the one who's going to decide whether they would need the next orthopedic step. And I think that's a critical point. In at least the United States, our patients are entering the funnel from the wrong direction. Like, why would you start with the intervention that's only used 1% of the time? That doesn't make any sense. So like, we're the perfect gatekeepers. We decide like whether or not we need to escalate treatment or not. Not escalate treatment, escalate like the next step. What do we need? Epidurals? Do we need surgery? Do we need, So I think that's like, we are in a perfect position to basically also act like a gatekeeper for that.
Beautiful. Good discussion. As always, just stick to function, guys. Like it will never let you down. And it makes it way more fun.
It makes it way more fun. Yeah. So if you're seeing patients tomorrow, I would just go all in on the function for a week and then let us know. I'm telling you, you will be reinvigorated with practice and it'll be fun again. And I'm excited for everybody to be bought in on that. Yeah.
One thing that, again, this is another plug. This is the third one of the episode, but we will talk a shit ton about function first weekend in November at the Neurodynamics World Congress. I mean, that is going to be literally the epitome of that weekend, and we'd love to see you there. As always, guys, keep auditing your patients, buy into function. Good luck with patients. And
if your treatment isn't changing your audits, then find new treatment. That's how we got to our core four, which is basically all of those are being represented at that seminar, because that is it. So if you're not changing those things, then change what you're doing, because that's what we're looking to change, and we're changing function of our patients.
Beautiful. All right, guys, good luck with patients. We'll see you next time. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.